Today our focus is only to introduce the conditions that would be evaluated by spirometry. And then on Thursday, we will discuss the process of evaluating using spirometry, what kind of results you might expect and how to interpret them, because then on Thursday afternoon you go right in the lab and you will be doing these same kind of measures. So we're only setting the stage now to understand the diseases, the conditions where you might want to use spirometry to evaluate function. I should make note as well before we get going too far, I have a couple of videos that really just solidify the concepts in the slide set. We'll look at them today. But in the past, those have been flagged when I upload the videos to YouTube, so I have to cut them out. So just pay attention to the videos now. They won't be in the uploaded versions. They're just little animations that emphasize everything we will have talked about by the time we get there. So the main chronic condition we're going to look at today is called chronic obstructive pulmonary disease, or COPD, one of the most common respiratory conditions or diseases that there is. We'll talk about how it develops, how prevalent it is. We'll compare our local community to the province and to the country as a whole. We'll get into that shortly. When we come back on Thursday, we will start to learn what these acronyms mean. They are components or characteristics of a type of test called a spirometric test. And we will learn to use different standard values to interpret results and diagnose pulmonary function. That should be corrected. Obvious little typo. So we will look not only at COPD, but a few other conditions. COPD will be the main focus. And then other respiratory conditions are almost like little offshoots. They can all be related to our discussion on COPD. Some of the same characteristics occur with things like asthma or sleep apnea, or COPD will contribute to some of those conditions. And I'm emphasizing throughout, this is especially true for Thursday's class when we look at the standard values for these types of figures and the standard measurements. I'm going to emphasize those, and I kind of do that throughout the course so that we can understand how to interpret the results we get in lab. And I think it's important because you will get a lot of standard values. You shouldn't be at a point where you've developed many of these conditions that we're going to talk about. But we're going to try to simulate them. We're going to create artificial COPD. So from a baseline where you know what the standard value should be, what each of these acronyms should be in a healthy person, we can move to a disease state to evaluate them there. So COPD, the main focus. Let's start with what it is and how prevalent it is. Chronic obstructive pulmonary disease. And this slide is all doom and gloom. Many people have COPD globally, and this rivals those that have type 2 diabetes. And I throw up diabetes as a comparison because it's probably one of the chronic diseases that you've heard about most, or you might be most familiar with, or you might know people that have some form of diabetes or are on their way to developing diabetes. For comparison, there are a similar number but more individuals that have COPD globally. And this contributes to a lot of deaths globally and in the developed world. In the US, it's ranked number 3 in leading causes of death, with 3 million people dying annually of COPD-related ailments. In Canada, it's number 4. We'll see that on the next slide. I think cancer and cardiovascular disease top the charts in the US. And I forget, we'll see it on the next slide, what the top 3 are in Canada. But the reasons that COPD is so prevalent and lethal if not contracted, because it's not, it's a chronic disease, you can't have it or not, it's progressive. The reasons that it seems to be so prevalent is that the gradual accumulated exposure to irritants in the air. Tobacco smoking, primary among them, both first and second-hand tobacco smoke exposure releases irritants that can inflame the airways and contribute to the progression of COPD. but particulate matter from pollution in our advanced society also contributes to COPD as well. Air pollution, chemicals at your job, some respiratory infections can make you more susceptible to these irritants. They don't necessarily cause COPD themselves, but your respiratory infections can make you more susceptible to accelerate the development later on in life. What's not on here that I'll reinforce a couple times throughout these slides is that COPD is not reversible. There's no cure. So the gradual accumulation over time is an ongoing march, and the more progression you have, the more you need to ease your quality of life and help to improve normal respiratory function, but you can't reverse the progression of the disease. So once you've progressed a certain amount, you can only make your life easier and tolerance to exercise easier at that level. You can't bring the symptoms back down afterwards. We'll talk about what the symptoms are shortly today. But doom and gloom, many people have COPD, many people die of COPD. Let's take a look at those numbers in context. So these are Stats Canada numbers as of 2014, which were the most recent numbers last year. It's possible they've updated, but I don't think that they have. You can see COPD here, number 4. These are listed in order for total all-cause mortality, number of incidences in the middle, the percentage of deaths in Canada on the right-hand side. Far and away, cancer by far leading the charge with a third of deaths annually. Heart disease, cerebrovascular disease, so stroke, brain aneurysms, number 3, and then COPD, number 4. And the numbers seem small at 4.5, 4.6%, but still nothing to ignore. Still something to be concerned about, because this is generally preventable. Accidents, for instance, not preventable. Cancer, so far, not preventable. Heart disease, stroke, somewhat preventable, but we'll talk about those later. So number 4, 4.6% of deaths annually in Canada. And this has increased in recent years. It's hard to say exactly why this acceleration has taken place. It's not the Industrial Revolution. That was the early 1800s. Around the 50s was really when we introduced smoking. It was cool in the 50s to smoke, and there was the increased adoption in society overall. Smoking was a common thing to do. Maybe they're related. It's simply anecdotal at this point, but you can see both sexes in red down the middle, men in dark blue, women in light blue. All trends upward, all increasing through the 60s, 70s, and hopefully stabilizing. There is some evidence to say that they've remained stable from 2010 onwards, and that's coming out. So maybe we've observed this rapid increase, now we're aware of it, and maybe we're putting measures into place to avoid it. Maybe we know smoking is not cool now. But we think this is largely due to an increase in smoking rates from 1950 onwards. It could be the accumulation of new or different kinds of pollutions. There was the big ozone layer scare in the 80s with CFCs. Maybe that contributes to it, but that's not the point. The point is there is an acceleration in the incidence, the deaths from COPD, which also parallels the incidence. We'll see that in a couple slides. 4.5%, which is what we saw on the last slide. This generally agrees, so our numbers come out in the wash. This is good. It's hard to speculate as to why there's separation in these lines. Any thoughts as to why there might be separation? Why is there such a higher incidence at any given point in time for men versus women? Women generally stop smoking when they get pregnant, or at least we hope so. Absolutely, yeah. So maybe throughout these developing years, there is a lower incidence of smoking in women. That doesn't explain why it accelerates more quickly. I totally buy that point, and that makes sense to me. At any given point in time, if you slice any of these years, fewer women might smoke than men. but they also seem to catch up faster. Men had this gradual increase over time, and women said in the 80s, nope, I'm not getting left behind. And there's this gradual, this rapid upregulation of deaths by COPD in women. So it's not that we hope they've decided to smoke during pregnancy. There's just this separation, which is really hard to speculate, and it could simply be now the increased stresses of work as we make steps towards work equality. Maybe cigarettes are seen as a relief from those kinds of stresses, or stresses around the home, or maybe they waited to take up smoking. It was only cool for men to do it in the 50s. The speculation is something that I'm not going to spend a lot of time on, but interesting to note that there is separation between the two. Regardless, we start at a similar point in the 50s, we end at a similar point in 2010, and from then on, it's been relatively stable. And from then on, I'm going to drill down a little bit more deeply. Rather than looking at Canada as a whole, I've broken out Nova Scotia, these middle sets of bars, and then our county. Pictou County, well, I guess it's not our county. Pictou County is technically over near New Glasgow, but this has Antigonish Strait, Nova Scotia as well. So as close to local as I can find. From 2010 onwards to our most recent set of data in 2014. This is incidence, number of persons, and percent. So percent is what we've looked at so far. 4.6% was deaths annually from COPD. These numbers are similar, although there is some discrepancy. And I'm comparing again to diabetes in each case. So Canada, COPD, the right-hand set of columns versus diabetes, and that is replicated in each set, just to give you to ground your expectations a little bit. One thing to notice, and this is true of almost every chronic disease that you look at, every incidence of health or descriptor of health, fruit and vegetable intake, leisure time physical activity, smoking, cancer, COPD, there's this relationship. There is some national average that is better than the provincial average in Nova Scotia, which is better than our local county average. That is, here where we live, we tend to see the worst case scenario. We are worse off than the province as a whole, which is worse off than the country as a whole when it comes to any index of health that you can look at. I haven't found one yet where this has not been the trend. There's a gradual trend for an increased prevalence of deaths due to COPD in our local county proper. There's less fruit and vegetable intake, less leisure time physical activity, less dietary fiber, fewer people wear helmets when cycling. Like everything that you can think of shows this trend, which is kind of striking. Which positions you really well if you happen to stay around here afterwards. There's a lot of job opportunity in promoting healthy lifestyle. We seem to be susceptible for whatever reason. Trend for higher incidence in Antigonish versus the province and Canada as a whole. Also, a fairly surprising percentage overall versus diabetes. Before this class, maybe you hadn't really heard of COPD very much. Diabetes we talk about all the time. Type 2 diabetes, the disease of affluence, of high income and lavish lifestyles, of sloth and gluttony. Of course, that's the lifestyle-related type 2 diabetes. Type 1 diabetes is a genetic disorder, which is slightly different. But a relatively high percentage over the past 5 years, if you average all these, the percentages up, 6.4% deaths due to COPD, 9.4% related to diabetes. Relatively high percent for something that you might not have heard about too much coming in. But good news is that it's been stable, relatively stable over the past 5 years. And it's difficult to look at our numbers locally because our data sets are relatively small, which is what these little asterisks mean here. But if you look provincially or at the national level, these rates of diabetes and the rates of COPD are all generally stable. So we don't have that continued increase in incidence, which is good. Provincially, a bit of fluctuation. I don't know if we can trust these numbers, but on average they stay pretty low even if they're fluctuating wildly. So generally stable over 5 years. Now we just want to turn the corner and see if we can decrease the incidence somewhat. Also, what's not immediately obvious from these numbers, because to think back to the last slide, comparing incidence on this slide, so how many people have COPD, to mortality, which was deaths due to COPD, generally line up. National average incidence in 2010 was 4.3% of people that had COPD. That matches the 4.3 to 4.6 that died due to COPD in 2010 as well. So incidence and mortality tend to line up. They seem to be related on almost a one-to-one basis, and that's because there is no cure. If you have COPD, you can expect that it might cause health complications later on in life. It can't be reversed. There is no cure. You can only improve your quality of life with the symptoms you have, but there's no cure for COPD. So, with an understanding of how prevalent it is and the severity of this condition, what is the condition? That's the next question. And COPD is an umbrella term for two underlying conditions: bronchitis and emphysema. Bronchitis and emphysema both occur together in the context of COPD. Bronchitis is the narrowing of airways. The airways in your lungs continue to branch and distribute air to the alveoli. When those airways narrow, it's harder for air to travel through them. When those airways narrow, the same volume of air can't move through as freely. There's an increased resistance to airflow. We'll talk about why the airways narrow coming up. And emphysema represents a breakdown of lung tissue, specifically elastic tissue. And so the shape of the alveoli and the alveolar sacs is largely related to the integrity of this elastic tissue. And as that breaks down, the sacs don't maintain their normal bubbled cluster of grapes shape. They start to swell and kind of languid and lose their elasticity, overall decreasing surface area. We studied last week why surface area is really important for gas exchange. We have a narrowing of airways and a breakdown of elastic tissue, which compromise normal lung function. So these two things are progressively worsened, and they both contribute to a condition called COPD. So COPD is the presence of these two elements. These two elements gradually get worse over time. Now, what are these two elements? So chronic bronchitis, the narrowing of airways, is largely related to the excess production of mucus and sputum and irritation of the airways from particulate matter, pollution, cigarette smoke, etc. So you can see those two things in the normal versus the bronchitis airway on the right-hand side. The walls of the airway are inflamed and reddened. They're thicker. They can't really expand outwards, and so the airway, the open space in the middle, closes off. And the production of mucus, this yellowy white substance, has also been increased. It collects along the inside of the walls of the airways and further limits the diameter of the airway. Both of those things, making the airway smaller, mean air can't flow in as high a volume. There's an increased resistance to airflow. You could move the same amount of air through a smaller space if you moved it faster. But moving it faster means more forceful breathing. It's a concept known as the work of breathing. And that's why in older individuals that have some form of bronchitis, it's a labor for them to breathe in and out. They're trying to accelerate air through all these really narrow passages with their increased resistance, and it takes a lot of energy to do that and cause a general pervasive sense of fatigue in the body. So bronchitis, narrowing of the airways, opposition to airflow, not as much air reaches the alveoli, the fresh supply of oxygen isn't renewed as readily, hence the lower pressure gradient to move oxygen in, and all of a sudden your O2 saturation in the blood starts to wane, starts to drop. Overall chain reaction of things that contribute to the symptoms of COPD. Next, emphysema. Emphysema, the breakdown of elastic tissue in the lungs. Why would the breakdown of elastic tissue in the lungs matter? I hinted at the idea that the alveoli, the alveolar sacs, their shape was maintained by this elastic tissue. But the dynamics of breathing also require healthy elastic tissue in order for air to move properly and for the structures to maintain their shape. So normally, on inspiration, we create negative pressure in the thorax. We lift the rib cage, negative pressure occurs in the thorax, pressure drops, and air moves in. And so when we have nice elastic alveoli and alveolar sacs, they expand, allowing air to move into them. Then on expiration, pressure jumps. We spike pressure in the thorax. That pushes air out, and that's how we breathe. That's how we ventilate. So if we lose that connective tissue, the compliance of the alveoli and the alveolar sacs is impacted. It's harder for them to expand and contract, and them expanding and contracting is what allows air to move directly to the alveoli. So we don't have that same stimulus to move, to ventilate air into the lungs. The breakdown of elastic tissue also compromises surface area for any air that makes it to the terminals. So this is a picture, a representation of a lung with emphysema on the right and a healthy lung or a healthy alveolar sac on the left. And you can see the breakdown of elastic tissue makes a lot more space. The walls are thinner, the passageways are larger, there's many more holes throughout, they're widened. If there's more space, that means the surface area must have decreased. For the same size alveolar sac, the tissue occupies much less space. So there's much less opportunity for gas to be exchanged. It's harder to move air. It's harder to exchange gas once that air is there, overall contributing to a lower O2 saturation and other ailments related to COPD. So a couple examples on the left-hand side. You can see a very similar cartoon depiction on the right-hand side of the worn-out elastic alveolar sacs versus healthy alveolar sacs. And what's not immediately intuitive is without the compliance of the alveolar sacs, the elastic tissue keeping shape, pressure has a much larger influence on those airways. So think about when you're breathing out. You've taken a deep breath in, and if you ever need to breathe out forcefully, you bring the rib cage down, you create a large positive pressure inside the lungs, which pushes air out of the trachea, the nose, the mouth, all the airways. If that happens, if the pressure is large enough in the thoracic cavity, and if the elastic tissue has broken down to a large enough degree, the pressure inside the thoracic cavity can pinch off these airways, can pinch off the small ducts that connect the alveolar sacs to the bronchioles. And so if these ducts are pinched off, it doesn't change the fact that there is air inside the alveolar sacs. It's effectively trapped. And it's trapped as we're trying to forcefully breathe out. So we pinch off the airways, And the pressure inside the alveolar sacs then jumps further as it's subject to all the pressure around without the option of air escaping. And that can cause further rupture and damage, not only to the alveolar sacs, but to the capillaries nearby, and severely limit lung function in that sense. So during expiration, you can see the schematic that we saw last week over on the right-hand side. If the alveolar pressure ever jumps higher than the arterial and venous pressure in the capillaries, it can pinch off blood flow. So not only do we have air trapped within the alveoli, we have blood interrupted and there's no flow through the capillaries. If the pressure is large enough, it can cause rupture. So a lot of potential for these characteristics of COPD to develop to a point where extensive damage can occur. But that being said, you don't jump from the left-hand figure to the right-hand figure overnight. It's a gradual progression, a gradual loss of elastic tissue, a gradual weakening of the capillaries. It's not instantaneous. How do all of these building blocks fit together? Generally, some aggravating agent will be inhaled. It could be acute exposure to tobacco smoke, it could be chemicals at your job, whatever the irritants are, somehow they are inhaled and they inflame the airways. Now, the epithelium in the airways being inflamed knows this is not something that should continue, and a protective mechanism that they have is to secrete mucus or sputum that lines the epithelium to protect it from those irritants. They can trap the irritants, you can then spit it up, cough it out so it doesn't impact the tissue proper. So mucus and or sputum, that thick, oily thick gooey substance secreted within the lungs to help protect against those irritants. As a result, we have an acute narrowing of the airways, not only from the inflammation, but also from the mucus production. That continued mucus and sputum production will protect the tissue, but if production continues to a large enough degree, some will be expelled or expectorated, we'll spit it out. Some can accumulate in the alveolar sacs and the finer airways, and there contributes to the breakdown of some of the fibrous and elastic tissues. Then the whole cycle repeats. If you have repeated exposure to aggravating agents, then you magnify this loop. It's only by removing whatever the agents are that are aggravating the airways that we stop the production of mucus, that we stop the narrowing of the airways, that we stop the breakdown of elastic and fibrous tissue. And so in this case, you think of a person that regularly smokes, the symptoms will often include a wheezing or hacking cough, a wet cough, always coughing up mucus, sputum, different colored substances which are not very appetizing or enticing. As the symptoms worsen and the loop continues, shortness of breath, even during mild exertion like walking upstairs, and that progresses to a point where the lightest exercise possible can't even be tolerated, where it's really hard to even get up from sitting in severe cases. So the loop continues. Only by removing the aggravating agents does the loop stop, but the loop can't be reversed. We can't all of a sudden build up the fibrous and elastic tissue. So in the context then of exercise, how is it that COPD impacts exercise? And it might be useful to go back to our transit time figure where we looked at how oxygen is normally transmitted from the lungs to the blood. In a normal situation, we have rapid and full gas exchange. So alveolar and arterial PO2s match. Even when we move to exercise, so transit time is severely limited. In a healthy individual, we still get near complete gas exchange. But in an abnormal situation, we're going to start to focus on these other lines now, where gas exchange is impeded for whatever reason. We have non-rapid and non-full gas exchange even at rest. Now, abnormal in this case is probably full-blown COPD. So it might be handy to think of some line in the middle where we would consider mild symptoms. You have had exposure to some smoke or chemicals. This is not really limiting, but there is some damage that, as it progresses, might result in full-blown abnormal gas exchange characteristic of COPD later in life. So mild symptoms, the gradual narrowing of airways and some breakdown of elastic tissue, would push this curve down and to the right. So this is a spectrum. As the symptoms worsen, this line will gradually flatten and move towards the abnormal curve. What does it mean if you have mild symptoms and gradually move towards the abnormal curve? Well, in a mild symptom sense, you don't feel anything at rest. In a mild, with a set of mild symptoms, we do get full gas exchange eventually within the 0.75 seconds that's characteristic of a resting transit time. With mild symptoms, normal everyday activities aren't affected, aren't impacted. But as we decrease transit time, which happens when we move to exercise, we start to see incomplete gas exchange. And so maybe to help make the point further, let's call this dashed line here, let's call this intense exercise. So really short transit time, heart's beating really quickly. And then we'll add another line over here that might be moderate or mild exercise. So 50% of VO2 max. A moderately increased heart rate, maybe 100 beats per minute. Normally, both of those conditions are satisfied. With mild symptoms, you might even be able to get up and move around at rest, moderate exercise, not impacted, but you'll start to see symptoms during intense exercise. Those symptoms will be borne out in the amount of oxygen that gets diffused. We can monitor O2 saturation. We can look at some other characteristics of breathing that we'll see later on in this week. As those symptoms worsen, you now can't even tolerate moderate exercise. In the abnormal case, you get incomplete diffusion of oxygen with intense and moderate exercise. Only the lightest activities of daily living are tenable. You get full gas exchange if you're sitting around watching TV, but as soon as you start to move around and do anything physically active, you will start to feel lightheaded or short of breath. And then in extreme circumstances, which require supplemental oxygen, you won't even get full gas exchange at rest. This is near complete breakdown of elastic tissue. This is severely limited airways in the grossly abnormal condition. But overall, you can imagine, as we go through this example, the progression from normal towards a full-blown abnormal COPD. The line gradually flattens and moves to the right as the symptoms worsen. Keep in mind, this is not curable, so as this curve flattens, it can't become unflattened. There are things that, I'm just going to stop myself there, we'll talk about the things that you can do later. So mild symptoms only present with intense exercise. Moderate symptoms can be apparent with any exercise. Severe symptoms might even be apparent at rest. That's what we're looking at here. So that long-winded description should be nicely summarized for you in this fun couple-minute video. a second as I see if this works.
Pulmonary disease, or COPD, is the gradual loss of your ability to breathe effectively. Normally, as you inhale, air moves freely through your trachea, or windpipe, then through large tubes called bronchi, smaller tubes called bronchioles, and finally into tiny sacs called alveoli. Small blood vessels called capillaries surround your alveoli. Oxygen from the air you breathe passes into your capillaries. Then carbon dioxide from your body passes out of your capillaries into your alveoli so that your lungs can get rid of it when you exhale. Normally, your airways and alveoli are flexible and springy. When you inhale, each air sac inflates like a small balloon. And when you exhale, the sacs deflate. Smoking is the leading cause of COPD. However, it may also be caused by long-term exposure to other irritants, such as air pollution, chemical fumes, and dust. If you have COPD, you have the two main conditions that make up the disease: emphysema and chronic bronchitis. In emphysema, your airways and air sacs lose their flexibility, making it harder for them to expand and contract. Emphysema destroys some of your air sac walls, leading to fewer, larger sacs that provide less area to absorb oxygen from the air you breathe. The symptoms of emphysema include wheezing, shortness of breath, and tightness in your chest. With chronic bronchitis, damage inside your airways causes the lining to swell, thicken, and make mucus. You develop a persistent cough as your body attempts to get rid of the extra mucus. The symptoms of chronic bronchitis include an ongoing cough that produces a lot of mucus, shortness of breath, and frequent respiratory infections. The damage done to your lungs by COPD cannot be reversed, and there is no cure for the disease. However, treatment can slow the progress of your disease and help you feel better. The most common treatments are quitting smoking, use of inhaled medicines to open your airways and reduce swelling, antibiotics for bronchitis caused by bacterial infection, oxygen therapy for those with advanced COPD and severely low levels of oxygen in their blood, and surgery, such as a bulectomy or lung volume reduction surgery to remove non-functioning air sacs. The best way to prevent yourself from getting COPD is to never smoke. If you are a smoker, quitting smoking reduces the chance you'll develop COPD. You can also limit your exposure to chemicals, fumes, and dusts that may cause COPD.
Nice. So repetitive. We heard all that already today, but my colorful descriptions can only get so far. Those 3D models, I think, are pretty cool to see the inflating and deflating alveoli and the gases moving back and forth. So if you smoke, stop, or never smoke, and then you won't have to worry about this. Bronchitis and emphysema, we know well as the elements that contribute to COPD, but they have secondary effects also. As you get older, if you've lost a lot of that elastic tissue and fibrous tissue, it's not only in the alveoli, the lower airways of the lungs that you realize that deficit, but in the upper respiratory tract as well, you can lose that springiness, that rigidity of the airways, and this contributes to a really common phenomenon called sleep apnea, where the airways collapse while you're sleeping. The person stops breathing and wakes up and start coughing, or may not even wake up, but the body reacts quickly to prevent a drastic, sharp drop in oxygen supply. So that loss of fibrous tissue can cause collapse, especially when you're sitting on your back, and you can see that here as the epiglottis falls against the back of the throat, back of the trachea. The tongue collapses inwards, and air isn't getting into or out of the lungs. And this has been linked to cardiac arrhythmias and some hypertension issues. Whether it causes them or is simply associated, we're not exactly sure right now, but I think there is some reason to think that there is at least a bit of a causative mechanism. So preventing sleep apnea certainly is a strategy that a lot of older people with this condition want to accomplish. And because this is not reversible, you can't regain that fibrous tissue. We need some exterior treatment, which is shown here, a CPAP mask, constant positive airway pressure mask, that helps to maintain open airways while you sleep. And I think on the slides that I gave you, I have all the answers here. I was going to stop and have like a little discussion. But we know from last week when gas exchange is not efficient, we don't get adequate loading of O2 or unloading of CO2. The consequence is high CO2 in the blood, not enough is being removed, and low oxygen in the blood, not enough is being added. So in COPD patients where they exhibit the characteristics of sleep apnea, overall over the course of the night, they become hypercapnic. They store or they gradually accumulate CO2 in the body because it's still metabolically active. And they become hypoxic because that new fresh air can't reach the lungs where it is exchanged. Now the CPAP mask, and you can maybe make out some of these statements here. I'm going to blow one up for you shortly. The CPAP mask will tend to change ventilation artificially. Constant positive airway pressure, really it's in the name, it tells you what it's trying to do. Constantly provide a positive airway pressure. It's like blowing up a balloon with your mouth right now. If you had a birthday party, you have to blow up 200 balloons, you're providing constant positive airway pressure to the balloon. Well, in this case, your lungs are the balloon and this machine is blowing up your lungs. And it sets ventilation primarily through, I don't have the answer on here. Primarily through what? Would you change tidal volume or frequency? Considering what we learned about how ventilation changes and the regulation of ventilation last week. Constant positive airway pressure can modify either tidal volume or frequency to increase ventilation. And what would you think would be the most appropriate? A machine that quickly pulses to increase frequency, or a machine that gradually widens and delivers more air to increase tidal volume? Second one, increasing tidal volume. Why would you want to increase tidal volume?
Because what's the point of doing like the fast frequency if it's going to put a lot of strain on the patient? Like why wouldn't you just want to increase the lungs so it gets more oxygen in and then you can pump it out?
Okay, so getting more oxygen in, I imagine, let's describe it this way. The quick pulsing and increasing of frequency decreases the time that air can move to the terminal point of the lung and back. So it's pushing and pulling, there's a tug of war going on, and there might not be enough time to deliver fresh air all the way to the alveoli. Whereas if you increase tidal volume, you have this long, constant push, complete delivery to the alveoli, and then this return of air back to the machine. Absolutely. If we think of the regulation of ventilation, why is it good that that's the strategy these machines take?
Wouldn't they be using the machines while they're sleeping? So you wouldn't want them to be like hyperventilating while they're sleeping.
Okay,
If that's
fantastic.
what the machine
Why is hyperventilating bad? Okay.
Which is probably the same thing I said twice.
No, that's true. What hyperventilation is what I want to dig into because we talked about that last class in the regulation section. How does breathing get regulated and how is it affected by hyperventilating? What's the thing that really is affected by hyperventilating? Right, you blow off a lot of CO2. So if you're hyperventilating and you force this person to lose a lot of CO2, that pulls that acid-base balance equation away from the bicarbonate side and you become alkalotic. I'll show you on a couple slides what that means exactly, but instead of becoming acidotic and proteins unraveling, you become alkalotic, which has its own set of complications. You don't want to change your normal neutral pH within the body, so you don't want to have the patient hyperventilating while they're asleep for 8 hours, which is why tidal volume is preferred. And you can see that over here if you were looking at these individual inset blurry paragraphs. The one that I'm covering over now on the right-hand side says constant positive airway pressure provides a larger tidal volume with the same inspiratory effort. So it's not harder for the patients to breathe. That work of breathing is decreased because the pressure is facilitating the movement of air. It improves alveolar ventilation or the delivery of fresh air all the way to the alveoli. It makes it easier for them to breathe. So alleviating the smaller airways and the resistance to airflow, not having them hyperventilate. And then there's also the consideration that maybe they would sense the frequency of breathing. Maybe the machine would be loud if it's doing that overnight. You want them to be comfortable and be able to sleep, which I haven't yet had to experience and hopefully won't for a while, but my father-in-law certainly does. It's another story. So constant positive airway pressure, a way that we can combat the decreased airway diameter and the loss of fibrous and elastic tissue that are characteristic of those COPD symptoms. Now, what I was referencing in the acid-base balance equation is generally shown here. So a person with COPD, and this could be a person that is hyperventilating, that would be hyperventilating overnight, or just a person with incomplete gas exchange, would move around on this figure. Now, what is this figure showing us, first and foremost? This is a map of how the body maintains a neutral pH. We want a neutral pH everywhere in the body. That's how our proteins function. That's how we're built. And in our case, neutral is around 7.4. That's our ideal pH. True neutral is 7. Alkalotic is 7.7 and above. Remember, the pH scale goes from, was it 2 to 13? Even I forget. 2 to 14? The pH scale? 1 to 14? 0 to 14? We're in the ballpark. We're not saying 0 to 100. We're in the ballpark. That's good. So we maintain pH within a very narrow range, all things considered. 1 to 13, 0 to 14, whatever it is. Our range is 0.7. And we want it maintained at an ideal neutral, quote unquote, pH of 7.4. And so for an individual that is living their normal life, they're at this center dot. At a pH of 7.4, they have some amount of bicarbonate in the blood, and this can change up and down to buffer any increased acidity that might occur, for instance, if you exercise. You do create an acidic environment when you exercise, and plasma bicarbonate is a way that we buffer that increased acidity. So an individual that hyperventilates, for instance, let's start with hypoventilate because my animations are ordered in that way. An individual with COPD that has incomplete gas exchange is said to be hypoventilating. So from this normal situation, they have incomplete loading of oxygen and incomplete offloading of CO2, hypercapnic hypoxia. what happens in a hypercapnic situation? High PCO2. And the answers are all in the slide. What's the first thing that would happen? High PCO2. Sorry? Okay, so higher PCO2 pushes our carbonic anhydrase equation to the right. This is a seesaw. If there's more substrates than products, we move it to the right so they're equal. We increase the production of hydrogen ions. The environment becomes more acidic. So in a hypercapnic situation, from this neutral black dot in the middle, because we are ventilating incompletely, we are creating a situation of respiratory acidosis. We aren't removing as much CO2 through normal ventilation. That CO2 accumulates. It creates an acidic environment. The reason for which is that we're not breathing adequately. So the acidosis is respiratory. There's a very acute, immediate shift. And you can do this sitting here. If you held your breath for a while, you would start to see a gradual decrease in pH, a shift towards a more acidotic environment. The incomplete ventilation causes respiratory acidosis. And if we could correct ventilation, we would move back towards this neutral point. So if you held your breath, the signals would build up that you need to stop holding your breath, blow off CO2, and it would push you back towards this ideal pH. But people with COPD can't do that. It's not that they're holding their breath voluntarily. Ventilation is limited physically. So they have this persistent leftward push towards respiratory acidosis. They're always ventilating inadequately. And so in order for them to maintain a normal body pH, they need something else to happen. They need some other mechanism. And that other mechanism is shown here as we slide up along this line. This is renal compensation as the kidneys reabsorb bicarbonate. They keep in more bicarbonate in the body to help balance the excessive hydrogen ion production. So people with COPD can maintain a somewhat normal pH. It's disrupted by the inadequate ventilation, but their kidneys, if they're functioning properly, can compensate by reabsorbing, retaining bicarbonate in the body. And that's where they end up at this top black circle that's labeled COPD. They would maintain much more plasma bicarbonate in an effort to correct for the respiratory acidosis and maintain their normal ideal pH of 7.4. The reverse is true as well. If you were hyperventilating constantly, I'm not sure what situation that would be, where you were always hyperventilating and always blowing off CO2. That would probably, would that be altitude? Yeah, one of the main stresses of hypoxia is to hyperventilate, to be able to fully load the blood with oxygen, but in so doing, you blow off excess CO2, a condition noted as respiratory alkalosis. And if that persists, respiratory alkalosis, your kidneys will compensate in kind by getting rid of extra bicarbonate to maintain this neutral pH. So notice all these compensations down the middle maintain a somewhat ideal pH of 7.4. We can acutely move leftwards or rightwards by changing how we breathe, but overall, given enough time, the chronic adaptations by the kidneys will bring the body pH back in line. So narrow range within which we regulate, this is whole body pH. For comparison, and I'm only throwing it up here, FYI, intense exercise, above lactate threshold, you produce a lot of acid. If you're looking right at the muscle where that acid's produced, pH might be 6.5. Overall, as a whole, it doesn't impact the body as much, but it does tend to shift away from this ideal pH of 7.4 towards maybe 7.1, 7.2. But right at the muscle, we can observe something in the 6.5 kind of range. But outside of that is not physiological. Just to give you an idea of the extended range, if you will, of pHs in the body. Still pretty narrow, all things considered. So I want to show you one last video, and then we're going to break for today because we've covered a lot of information so far.
Diagnosis and evaluation of chronic obstructive pulmonary disease, COPD. Early detection of COPD is essential for those who may be at risk. Once the disease is diagnosed, treatment can be started that can slow down or help prevent further damage from occurring to the lungs. An ongoing cough with mucus production is often an early sign of COPD. Daily coughing is not normal and could be the sign of serious lung conditions. Individuals who have a history of smoking or repeated exposure to lung irritants should ask their healthcare professional for a breathing test called spirometry to determine if the symptoms they are experiencing are due to COPD. The earlier COPD is diagnosed, the better for patient outcomes. Once COPD is identified, there are effective medications that can help patients do more and can help lower the chances of having COPD flares or acute exacerbations of COPD. If prevented from progressing, patients with a mild stage of COPD can live a fairly normal life. Patients with moderate to severe stages of COPD have a greater risk to their health and worse outcomes than those who are diagnosed with milder forms of the disease. In mild cases of COPD, respiratory systems may not be recognized or may not be very troublesome. These individuals may be unaware they have COPD because people may mistakenly think that their cough is just a smoker's cough. The fact is, there is no such thing as a normal smoker's cough. Others with COPD may feel tired and experience uncomfortable breathing during physical activities. As a result, they stop being as active. These feelings of fatigue and trouble with activities may be due to COPD. If an early diagnosis is confirmed, patients will be able to receive the appropriate medical care to reduce the progression of the disease and its symptoms. Take a look at these patients. Can you tell which ones, if any, have COPD? Many people, even many healthcare professionals, believe that you can tell who has COPD based on their symptoms, risk factors, physical examination, and appearance. But this is a myth. The reality is that a breathing test, or lung function test called spirometry, is required to diagnose anyone with COPD. There are many other conditions that can be confused with COPD. People who have trouble breathing and have a cough may have COPD, but they may have other conditions like heart failure, scarring of the lungs, called fibrosis, asthma, or other breathing problems instead of COPD. This is why it is essential for you to get a breathing test, called spirometry, to be sure that your symptoms are due to COPD and not because of another condition. Based on your symptoms, your exposures to smoke and other lung irritants, and your medical history, your healthcare provider may order a breathing test called spirometry, which may also be called a lung function test or a pulmonary function test. During spirometry, you will be asked to take a deep breath and then exhale as hard and as fast as you can into a tube that is connected to a machine called the spirometer. This test measures how much air you can breathe out and how fast you blow air out. This test is simple, quick, painless, and accurate. Spirometry can predict COPD before symptoms are noticed or recognized. How fast air exits the lungs within the first second is called the forced expiratory volume, or FEV1, and indicates how well your lungs work or function. The spirometer allows your healthcare provider to compare your results against healthy individuals of similar age, height, gender, and ethnicity. In patients who already have COPD, spirometry is helpful to monitor changes in lung function, especially if done a month or two after a lung attack, also known as a COPD flare or an acute exacerbation of COPD. Some people get a cold or bronchitis that lasts for several days or even weeks.
We don't need the rest of that. So this prefaces what we're going to talk about in class on Thursday, how we use spirometry and what those numbers mean. You saw the definition of one of those acronyms. Doesn't really matter what it is right now, but we'll talk about how it works coming up on Thursday. So that's it. Have a wonderful Tuesday, and see you then.